Thank you very much, Mr. Kirkuson. Ladies and gentlemen, it is my great privilege to be invited to Central Asia Arrhyhmia Summit, and I appreciate you, Professor Abdrahmanov. According to the 2024 ESCC guidelines, antiarrhythmic drug-resistant atrial fibrillation, symptomatic paroxysmal atrial fibrillation with HFrEF, all these are class 1 indication for AF catheter ablation. Naturally, the frequency and volume of AF catheter ablation procedures are rapidly increasing at each centers. While the effectiveness of catheter ablation is important, it is our EP physicians' responsibility to safely return patients to their daily lives after the successful procedure. This is fairly old data, but it is a statistical study on AF catheter ablation complications. Multicenter outcome of complication risk after radiofrequency catheter ablation and overall complication risk was 5.9% in 2005, 4.5% in 2010, and 2.3% in our institution 2019. However, the introduction and commercialization of pulsed field ablation is expected to further reduce the risk of such catheter ablation related to AF catheter ablation. These are the results of Manifest 17 case study, which evaluated the pulsed field ablation safety in over 17,000 patients, and PFA PVI complication risk is virtually non-existent other than the vascular complication. Although rare complications such as coronary spasm or hemolysis were uncommon in radiofrequency PV isolation can occur, their frequency is extremely low. So the complications associated with thermal ablation such as PV stenosis, esophageal damage, and/or cranial paralysis do not occur at all by utilizing the pulsed field ablation. Now, let's take a closer look at the AF catheter ablation complications and how to reduce their risk. Cardiac tamponade is the most common major complication experienced by inexperienced operators. Beginners should be especially careful about the left atrial appendage perforation. In LAO view or AP view, it is difficult to distinguish whether the catheter location in LSPV or left atrial appendage. It is clearly distinguished in RAO view, but the easiest way is to always watching the electrogram. As you can see, the left atrial appendage potential has a large voltage and width than PV potential, making it easy to distinguish. The part that an operator who is a little familiar with it should be careful about the right superior pulmonic vein group area ablation. Okay, the contact force in this area is very unstable, so it can create a gap or cause perforation. If a cardiac tamponade is made in this area, it will be difficult for surgeons to find the area. It is because it is buried between pulmonary arteries and main bronchus. So the hemopericardial complication have been significantly reduced with use of contact force catheter. But to ensure safe procedure, management protocol, and training of operating room staffs are necessary. The most common complication associated with AF ablation might be vascular complication, and most of them are minor complication at the vascular access side. But the major complications such as coronary artery injury or PV stenosis also require attention. Recently, the use of vascular ultrasound for femoral access has almost eliminated the risk of growing complication. And in this meta-analysis, found that vascular ultrasound reduced the risk of growing complication by more than 70%. And the 2024 guidelines also recommend to use this vascular ultrasound. Recently, the diameter of PFA or cryoballoon catheter, the shears, delivering shears have increased. So the use of venous vascular closure for post-procedural hemostasis can reduce time to absolute hemostasis for patient. In this study, the RCT comparing venous closure versus the figure 8 suture found that the time to hemostasis was shortened to less than 2 hours with no difference in the risk of growing complication. PV stenosis remains a major complication after hypersaturation RA population. During hypersaturation AF population, more than 1,000 patients, the procedure time was significantly reduced and there was no difference in efficacy. Surprisingly, some patients complained of dyspnea 6 months to 1 year after the procedure. This chronic PV stenosis was observed in 0.4% of patients despite the enteral PV isolation. It was significantly higher incidence than conventional ablation. It is common in proximal AF, young men, redo procedure, and inferior veins. In these patients, the RF delivery time should be further reduced. Recently, PV touch-up ablation can be reduced using near-field potential guided ablation. Near-field potential distinguishes endocardial exit site from epicardial far-field potential, and when looking for the PV gaps, near-field potential detects endocardial exit more accurately than epicardial conduction, which is identified as conventional first deflection. So PV isolation was achieved by a single burn at this location in this specific case. Although rare, there is a risk of coronary artery injury and the left lateral isthmus ablation, in particular, can result in left circumflex coronary artery injury. PFA is not immune to coronary artery injury. PFA-induced coronary spasm and intima growth have been documented in human patients and animal studies. Next, the risk of thromboembolic complication must be considered. Guideline recommends anticoagulation at least for 1 month before catheter ablation procedure, and they recommend warfarin without interruption before the procedure and NOAA without interruption or skipping on single morning dose. In our study, regardless of type of NOAC, the morning dose skip NOAC strategy did not affect the thromboembolic risk after the procedure. Stroke rate is greatly reduced with an uninterrupted warfarin strategy or single dose skip NOAC and maintaining ACT over 350 during the procedure. And good tissue contact is very important for stroke prevention when you use a PFA. Nonetheless, a rare 0.2% risk of peri-procedural stroke still exists. Silent cerebral lesions are not accompanied by neurologic symptoms, but may result in cognitive decline. Therefore, we should avoid silent cerebral lesions because they are procedure-related microembolic events. Calvert recommends the following in his review article. He recommends irrigative radiofrequency catheter, short LA indwelling time, withdrawal reinsertion of a cryoballoon catheter should be avoided. We have to avoid ablation and mapping catheter exchange as much as possible using single transept approach. It is recommended that cardioversion be postponed until 4 weeks after the procedure. Of course, uninterrupted OAC, and the ACT over 300 during the procedure are required. Next is collateral damage to adjacent structures. Atrial esophageal fistula is the most catastrophic complication of AF catheter ablation. PFA has been proven to be relatively safe for this complication, but it is a fatal complication with 0.04% risk when RF or cryothermal energy is used. Here is the location of esophageal contact area with LA posterior wall. The closest point of esophagus to PV is just behind the left inferior pulmonic vein. In particular, the risk is much higher in patients with short chest AP diameter using the esophagus to be entrapped between vertebra and aorta. Therefore, I strongly recommend the pre-procedural careful CT review and using esophageal temperature probe. A-fistula never appears immediately after the procedure. Presentation with stroke or sepsis occurs 3 to 8 weeks after the procedure. The earliest diagnosis might be the cardiac CT scan, but the fatality is over 70% even after surgery or esophageal stents. How to avoid a fistula? Keep in mind the left inferior pulmonary vein posterior aspect is a dangerous area. Use the esophageal temperature probe, and you need to adjust the probe location on the RF ablation site and reduce RF power. General anesthesia increase the risk of esophageal injury. Use PFA, PPI, and antibiotics in patients with leukocytosis. Generally, 3 to 8 weeks after the procedure. Esophageal symptom, fever, or stroke, those are the cardinal signs of a fistula. And cardiac CT scan first for suspicious patients. Okay, next one is coronary atrial fistula. It is also very rarely developed after extensive posterior wall isolation. We found very unusual echo color Doppler on the LA posterior wall in this case. And the CT scan and coronary angiogram confirmed this rare complication of coronary atrial fistula. RF or cryo-energy may damage the nerves, but not by PFA. It's like the two sides of coin, and negative aspects and positive effects. Right side flying nerve paralysis can occur because the flying nerve located between SVC and right superior pulmonary vein anterior aspects. Especially after the prior PBI, right side flying nerve paralysis occurs in about 2%, but usually recovers. In contrast, autonomic nerve modulation could be an important target of AF rhythm control. We previously reported that the post-ablation third month heart rate variability reflecting the parasympathetic nerve activity was significantly reduced in no recurrence group and very late recurrence group, but not in patients with recurrence within a year. And these RCTs, SV septal linear ablation, which targets third fat pad, maintaining the autonomic modulation longer time and improve the rhythm outcome as compared with PB isolation alone in patients with paroxysmal or persistent AFib. The CROWD trial is an RCT that evaluated the effect of a right atrial ablation in 289 patients with persistent AFib. And cryo PBI was performed to homogenize PBI lesion set, and groups that underwent additional right atrial SV septal linear ablation and cable tractors isthmus ablation was compared with PBI alone group, and right atrial ablation significantly reduced the recurrence rate of persistent AFib ablation. However, it is uncertain whether the current PFA catheter design can safely create such right atrial lesion. This study compared the effect of ganglionate plaque stimulation in low voltage area after pulse-field ablation. Unlike cryo-RF, there was no change in post-procedural heart rate after PFA, and GP stimulation response recovered in 60% of cases. This indicates that PFA has minimal autonomic denervation effects. Finally, let us discuss about post-procedural bradyarrhythmias. In AF patients with advanced remodeling, sinus node dysfunction often accompanies it. However, in most patients, bradycardia often improves after AF ablation by reverse electrical remodeling of sinus node. I will briefly explain our institution's data on patients with proximal atrial fibrillation with sinus node dysfunction. For AF patient with pacemaker class 1 indication, we performed the AF catheter ablation first. As a result, 8 out of 9 patients have been doing well more than 3 years without pacemaker in this study. Of course, there are also cases where the elderly patient undergoing the long-term follow-up and have pacemaker implantation eventually. One complication I'd like to mention is post-procedural sinus node dysfunction due to sinus nodal coronary artery injury. The sinus node has dual blood supply from RCA and circumflex, and rarely sinus node dysfunction can occur after anterior linear ablation due to injury the left sinus nodal coronary artery embedded within the Bachmann's bundle. Okay, finally, this is my conclusion, ladies and gentlemen. To avoid the complication of AF catheter ablation, needs to make sways, understand the detailed cardiac anatomy, never push catheter without electron, do not trust the 3D map too much, listen to the patient complaint, control patient respiration, operators concentration saves the patient. Finally, make a good surgeon friend. Thank you very much for your attention.